Everyone thinks ADHD is just like you can't pay attention, you're spacing out all the time, but it is an extreme form of executive dysfunction. They're what regulate attention, our emotions, motivation, impulse control, and our ability to plan and organize. And so with ADHD, that executive dysfunction, it impacts your life, your school life, your work life, your relation life in such a significant way that it is disabling. Now, I say that because everyone has some form of executive dysfunction. There is something in our life that maybe we're bad with time, or maybe we have a really hard time motivating ourselves, or maybe we're in perimenopause, our hormones have changed and it feels like we have ADHD, but it's not in fact ADHD.
All right. Well, it's a real pleasure to have Dr. Jolene Brighten on the show today. Welcome.
Yes, thanks for having me.
It's actually so fun to have you here because I have been following you like years ago. I don't know, I feel like 10 years ago or something. And
oh no, you're telling on us we're old.
yeah, you've been around for a long time. And then I remember going, God, this is really good for my daughter. Because if we were talking about perimenopause, you were talking a lot about just hormones, so many other things that are related to my daughter. So I told her, like, okay, you got to go start following Dr. Jolene because she's got really good information for you in birth control. And I remember all these topics that I wanted her to be informed on. And then you just kind of came back in my life again. You're all perimenopause, menopause, and now you're really into ADHD and that topic. And I don't think we've ever really covered in depth ADHD. We just kind of throw that word around as if everybody knows what it is. And I'd love for you to start by clarifying what is ADHD and how does somebody know if they have it?
Right. Everyone thinks ADHD is just like you can't pay attention, you're spacing out all the time. But ADHD is an extreme form of executive dysfunction. And so what does that mean? So our executive functions, they're what regulate our attention, our emotions, motivation, impulse control, and our ability to plan and organize. And so with ADHD, that executive dysfunction, it impacts your life. So your school life, your work life, your relation life in such a significant way that it is disabling. Now, I say that because everyone has some form of executive dysfunction. There is something in our life that maybe we're bad with time, or maybe we have a really hard time motivating ourselves, or maybe we're in perimenopause, our hormones have changed and it feels like we have ADHD, but it's not in fact ADHD.
So that's because, you're right. So many of the symptoms would so be related to menopause. And how does somebody then decide if it's menopause or if it's really ADHD?
That's a great question. So with ADHD, it's a neurodevelopmental disorder. So the majority of us were born with it. You can develop it after a traumatic brain injury or brain infection, something that alters the wiring, so to speak. So you've had struggles your entire life, but because you have estrogen working for you, you've got testosterone, DHEA, progesterone, most of us have pretty good blood sugar balance. We're like a lot more metabolically flexible as we're younger. We can overcome and we can compensate for ADHD. Once we enter perimenopause, though, and the hormones start to shift, our brain energy shifts, our neuroinflammation increases, we no longer can pretend, mask, or compensate because we just don't have the energy for it anymore. And that's when everything starts to fall apart and we're like, my ADHD has exploded. It's the worst it is. The noise volume knob has been turned way up on this. Or do I have onset ADHD? Now, the difference is in a perimenopausal woman is that she'll have never experienced these symptoms before. She'll look back and she'll say, no, I never had problems like blurting out the answer, interrupting people. I never struggled with relationships. I never felt like I was the odd one out. I sometimes ran late, but it wasn't like such this heavy weight on me that I was having anxiety all the time. So I was chronically an hour early. Like they don't have that in their story. You talk to their parents, they're like, no, this was not an issue. They sat still in class. They didn't struggle with anxiety. So you get this whole history from childhood that looks very different. Now, what is so important to understand, and I talk about this in my book, ADHD and Women, and the book is geared for ADHD women, but it is the brain solution for those who are not ADHD, but are experiencing ADHD-like symptoms in perimenopause. The good news for you is that if you have a non-ADHD brain, those ADHD-like symptoms should resolve within about 18 months to 2 years after your final period. So final period's menopause, next day you're postmenopausal. A couple years in, your brain's going to recover. The bad news is if you do have ADHD, roughly 25% of women will go into postmenopausal years with the most severe ADHD symptoms that never let up for the rest of their life. So this is why it's really important for us to understand, do you have ADHD? Do you not have ADHD? And how do we address you? And also, how do we set you up for success long term? Because I, for one, believe that the 25% of your life or more that is spent postmenopausal should still be some of your best years. And we shouldn't just say, oh, well, you're older. Like, it's all downhill from here.
So it sounds almost that what I'm hearing is, you know, if you have ADHD, like you've had it. It's not like you suddenly get it unless you had a traumatic brain injury. It's more likely menopausal symptoms if it's something coming out of nowhere. But what I'm hearing you say also is that if you do have an ADHD brain and you're going through menopause, it's exacerbated. It's going to be a rougher ride, maybe than everything else. You were able to manage it with your hormones before, and now it's just kind of really disrupting and getting out of control. Is that correct?
And to your point, like, you'll know that you have ADHD? Not necessarily. So a lot of women are now being diagnosed in perimenopausal years, and it is because for the first time ever, they're presented with all the ADHD symptoms while their child is being evaluated. And once their child's being evaluated, they're like, wait a minute, this was me through childhood. This is me now. Like, now I see myself in this, and they get evaluated. Because most of their life, they've been labeled with things that you're just lazy, you just don't try enough, or you're too much, too talkative, too interruptive, too lazy, and they've been labeled all these things, but also that they're more likely to be diagnosed with depression and anxiety and have their ADHD ignored. So they may not know they have ADHD until they actually get presented with what the diagnostic criteria is.
Okay, so if somebody suspects they have ADHD, then what's the process actually to get diagnosed with this?
Yes, so to get diagnosed with ADHD, you're going to need to meet with a psychiatrist, a psychologist, a social worker, somebody in mental health that's going to do the screening exam. And so we've seen the explosion of people self-diagnosing because they've seen a TikTok. I think self-diagnosis is valid when you do it correctly. And it's not like, oh, we're just all a little ADHD kind of flippant about it. But what we look for is we're going to look at your childhood history. We're going to look at your school history, your family history. There is a symptom checklist of determining, are you inattentive type? You might have been labeled as a space cadet when you were younger. Or looking at, do you have hyperactivity, which for women tends to be more mental than physical. They're also going to evaluate your current functioning. And then we always ask the question, could something else explain this? So, for example, hypothyroidism, because it significantly impacts brain energy, inflammation in the brain, and neurotransmitters, it can parade around as ADHD, but in reality, it's hypothyroidism. That's not to say you can't have both, because you absolutely can have both, but we have to rule these things in or out and make sure that, like, we're not diagnosing someone with ADHD and then missing something more significant. This person might have sleep apnea, for example. And why do I say more significant? Well, because they're going to have a higher risk of cardiovascular disease, and it would be a shame to say, well, it's just ADHD and not do that cardio workup as well.
That's a really good point, really important too. So is there a spectrum to ADHD, people who have more and less of it?
We don't think about ADHD in the same way that we think about autism being on a spectrum in terms of the needs, the level of support. But with ADHD, there are different types. So we've got the hyperactive archetype, which we all think of ADHD as like that little boy bouncing off the walls in the classroom, the teacher that's like, can you just sit still? So there's that hyperactivity, a lot of generating of energy. Then there's the inattentive, the person who spaces out, the person who checks out mentally, that retreats into their mind. And then we've got a combination. So you can have both of those things going on. So like I said, for women, you might be that inattentive type that spaces out, but at the same time, you have a lot of mental hyperactivity going on and you're very restless. And this is most pronounced as women are trying to fall asleep at night, and we'll just see that their mind cannot stop. And so women will say, I try to fall asleep at night and my brain will not shut up.
Yeah. Then I'm also wondering, then the woman who's going through her whole life course and with ADHD, I'm picturing her stress hormones going up and down and all over the place and much higher than someone else, perhaps. And maybe I'm wrong, so correct me if I'm wrong. And we know the impact that has on the body in terms of your health. And what really is the impact of the hormones or of the stress or the cortisol, whatever it is that's related to ADHD, on the body?
Yes. So in my book, I actually have these ADHD hormone profiles that I have women take a quiz. They understand which hormones are most impacting how their executive function is operating. And cortisol is definitely one of those. So what is interesting about cortisol is that in the acute short term, you get stressed really quickly, your brain works better. But when you're under chronic stress, which is a lot of the ADHD experience for women because of the expectations society has on us, but also we can think about how the research tells us if somebody is left-handed, the world is a lot more stressful because it's not designed for them. And we know the same is true for ADHD. And so when we have this chronic elevation of cortisol, we actually clear dopamine quicker. So you've got these two cells, and what sits in between is where your neurotransmitters are, and then they should dock onto the receptors. But when you have ADHD, when you have high cortisol with ADHD, you're clearing that dopamine quicker. And it's also not docking on the receptor. So the dopamine can't actually do its job. And so what we'll see is short-term stress, you're dialed in. This is why ADHDers, you'll ask them, when do you do your best work? And they'll say an hour before it's due, or the night before I have to give the presentation. Like that acute stress makes their dopamine work better. But when they doing that repeatedly, plus all the other stress in their life, and then they end up being caretakers as well, which is what we see in middle age. We might be sandwiched between caretaking parents and caretaking children. That overload of stress is to their detriment. And now they can no longer focus. Their ability to regulate attention. So ADHD, we call it attention deficit, but it's not really that you have a deficit. You have problems regulating your attention. And the boring things that don't get your dopamine up, like the doom pile of clothes you've stepped over 20 times this week, you don't have the motivation to get there. Not to mention that estrogen is a key player in affecting those motivation molecules as well.
You said it's not like a spectrum. It's kind of all in or nothing. When you explained it in the beginning, it sounded like there were different sectors, different parts, people who have different traits, I guess. Is that correct?
The tricky thing is that we're all going to struggle with executive dysfunction with ADHD, but some of us are going to have a much harder time in some areas. So for me, it's going to be in my luteal phase that my time blindness becomes so bad that I'm setting tons of alarms and I'm still not getting it right. That my husband is like yelling at me being like, we have to go in 5 minutes. Why are you naked in the closet right now? What is going on with you? And because my ability to work with time and to say, I have to leave at 11, therefore I should start getting ready at 9:30 and I need to have these things done by this time in order to make it out the door, my brain spatially cannot do that. And what's happening is that in the luteal phase, so this estrogen decline that we have in the luteal phase, it's not really that your estrogen drops as much as that progesterone rises so exponentially high that it makes it feel like estrogen has dropped. And so estrogen is stimulating serotonin, acetylcholine, dopamine, all of your neurotransmitters, norepinephrine to work correctly. And so when progesterone comes in, that's all about the GABA, the stop break, the slow it down. It can be really hard. So for women, because we have these hormonal allies, it can feel like, oh, well, my ADHD wasn't as bad, but if you ask them about like, how was it 3 to 5 days before your period? Oh my God, I couldn't even get out of the house. I missed deadlines. I can't take tests during that time. There's that history in there. And that is a little sneak peek of what perimenopause is going to be like. So for women with ADHD, what's been left out of the conversation is that so many of us have relied on our hormones. It's what makes our ADHD look different from men. It's what also makes it that we are still able to compensate in some ways. The other important aspect of ADHD is that we understand one of the most important factors in longevity, your survival as a human, is community. Lack of community, social isolation is as bad as smoking 15 cigarettes a day. The ADHD brain knowing this, and especially being a woman, is going to put all their energy into seeming like they fit in, into showing up and people pleasing, in doing all the things right so that they have access to community. I frame it in this way because people often see masking, which is trying to emulate your peers, trying to seem like you're normal, you understand what's going on, you get the joke every time. People will see that as, oh, that's nefarious, like you're trying to hide who you are. But it's not. It's an adaptation to make sure that you have access to community, which we understand as organisms is everything in our survival and our longevity. But as we get older, as you could imagine, constantly surveying yourself. What is my face doing right now? Am I saying the right things? Okay, I'm thinking of this stuff. Don't interrupt this person because they know that's rude, but I don't have enough acetylcholine to remember what I'm going to say again. So like, how do I track this? That's so much mental energy. So when you go into perimenopause and now the mitochondria, the powerhouse of your cells, starts to struggle with energy production, you can imagine how the masking starts to fall away. You're no longer able to do that. You just don't have the brain energy.
It really sounds just like anyone who's going through perimenopause in many ways, it's just 10x. It's probably harder anyways for somebody who's really struggling with that. And so you give a lot of great tips. Actually, you have a great YouTube channel, which I'll have a link in the show notes, because that's where I learn a lot of stuff from you. That's where I consume most of the content from you. And I would love for you to share then, how can a woman go through this transition with the ADHD and knowing that, okay, this is going to be a tough one? What should she be doing and thinking about first in order to make that transition a little smoother?
Yes. So I definitely want to talk about nutrition and lifestyle tips because I'm a fan of the things that you can do at home that don't require a prescription. However, to your point, saying that ADHD is harder in perimenopause, it absolutely is. In fact, we've had studies come out showing us just how difficult things can be for the ADHD brain in perimenopause. And one study in particular cited that ADHD women are transitioning through perimenopause about a decade earlier, so it comes sooner. And the symptoms are about twice as severe. So they're dealing with the same symptoms as everyone else, but the severity is so much more amplified. And I think that's important to understand because if we understand that peak perimenopause for the ADHD brain may be on average 35 to 39 years old, then we need to start having conversations at 32 years old about hormone therapy. And that is not to say that you have to do hormone therapy, but it is to say that we should have that conversation so that you know the pros, the cons, you get the informed consent. And then when the symptoms start, you don't feel in a panic like you have to just make this decision tomorrow. You just have to start something. You just have to do something about this. It's going to feel that way. That is what perimenopause feels like, is that things are slipping away. It's like you're trying to grab onto sand and it's slipping through your fingers. And no matter how hard you fight and you try, you're losing your grip on everything that you used to have seemingly mastered in your life. So I think that's the first thing. Is understanding, okay, what are my options for hormone therapy? Because if we intervene with, for example, estrogen sooner, then we don't have that as significant of a deficit in the brain energy that we may have experienced. Now, what's important to understand for women with ADHD is that part of the underlying issue of ADHD is what I call the hormone immune brain triad. And that is you are already experiencing immune system dysregulation. You have more neuroinflammation oftentimes. Sitting in the middle of that is the mitochondria, which are already having a harder time producing energy. ADHD brains typically have issues with utilizing glucose. This is the preferred form of energy for the brain. So as your hormones shift, so do all of those patterns. And that happens for everybody. I mean, Dr. Lisa Mosconi's work shows that by the time a woman is postmenopausal, it's almost 20% reduction in her energy production in her brain. Now, you have ADHD. You already had a deficit in all of that. And that is why I don't think it's right for us to say, we're going to wait until your symptoms are severe and then intervene with hormones, because your brain has already been struggling. Now, the other thing I would say is that if you have a history of PMDD, whether or not you know if you have premenstrual dysphoric disorder and you've officially been diagnosed, if you're somebody who 10 days before your period, a dark cloud moves in and is the hardest mental period of your life, you may be someone who's overly sensitive to progesterone. That's good information for us to know ahead of time because that's the first hormone to go in perimenopause. We cannot give you estrogen without you taking progesterone. The majority of menopause societies that are out there, including the Menopause Society in the US, they say it needs to be oral progesterone to protect the endometrial lining. However, that releases a huge bolus of allopregnanolone for some people, which is the neurosteroid metabolite that affects the GABA receptor in the brain. And for some women, they don't have the plasticity in the brain to adapt to those changes. Fortunately, the British Menopause Society now says vaginal estrogen can be an alternative. You have to dose it at the same dose, sometimes higher though, to protect the endometrial lining. But we need to know that ahead of time because for some women who have severe PMDD, a history of that, we start them on oral estrogen and they have extreme symptoms and they're at risk of self-harm. So this is why we've got to start having these conversations sooner for the neurodivergent brain so that we can understand what's going to be the best therapy for you. What are we going to try to help your brain work at its best?
Do you know if somebody follows this formula that you're talking about now? She's like, okay, I'm now 32, I'm going to inform myself. When she gets to 35 or closer to 40, she's like, okay, I think I'm ready to get started with some kind of hormone therapy. Is it better that she slowly starts taking things even while she still has her hormones, rather than wait until she falls off a cliff, zero hormones, maybe even wait some women 5-10 years after menopause and they start considering it, but their receptors are maybe not, they're very sensitive and they don't respond as the same. Is that what you would think would happen to a woman who's got ADHD, who's going through this transition?
Yeah. This is a really smart question. And this is the question that research is starting to ask a lot more and hinting at how can we do this better. So we know currently there is a 10-year critical window hypothesis. So within 10 years of your period stopping, that's the ideal. If we're going to do anything for your brain, your heart, your bones, it needs to happen in that 10 years. However, research is now looking at, well, why in the heck are we letting women struggle and waiting until their period starts to drop off? So in my clinical practice, the way I've always addressed it is that the first hormone to go is progesterone. Sometimes testosterone's leaving with it. Sometimes testosterone always stays strong in women. They never need testosterone therapy. So it always just depends on the individual. But progesterone will go. And why is that? We only make progesterone following ovulation. And what's left behind is a temporary endocrine structure known as the corpus luteum. That corpus luteum, even if you ovulate, can start to become weak as we're in our 40s and sometimes even sooner. So now you don't make enough progesterone. And what that's going to show up as is you're not sleeping at night. You're having night waking. You don't get the deep sleep that you need to actually detox the brain. The lymphatic system, which is the detox system of the brain, can't run efficiently. And you're starting to have a lot more anxiety, a lot more rage. You're having more emotional dysregulation as the symptom picture of your executive dysfunction in the ADHD conversation. Now, of course, this can happen to all women. They can be experiencing this. So progesterone is the one we typically start with. And because a woman still has her period, we'll do that cyclically. So we will try to estimate when you ovulate. Oftentimes what I ask my patients to do is wear a wearable device, something like an Oura Ring, an Apple Watch, integrate that with natural cycles perhaps, but something that shows a temperature spike. And then we're going to start progesterone following that temperature spike. And we're going to use it for about 12 to 14 days, just depending on what her cycle has been. If you're someone who is over 35 now and your luteal phase, that is from ovulation until your next period, is less than 10 days, that's a sign that we need progesterone. So that's typically where we start because that's going to help with the GABA system. And GABA, as my good friend Dr. Carrie Jones always puts it, it's the mouth filter. It helps you so that you don't say the wrong thing, so that you filter and you self-monitor yourself and you have some breaks there. So you're not a chronic conversation interrupter. And so GABA can be really important for sleep as well. Then as things progress and the symptoms I look for, so a lot of times doctors are looking for hot flashes, night sweats. I start to look for other things sooner. Are you starting to have cognitive changes? You can't remember why you went in the room. You can't remember what you're saying mid-sentence. It's impacting your work. It's impacting your mothering. It's impacting your life in a significant way. Like you're noticing it and other people are probably starting to notice it too. That's a good time to start thinking about estrogen. And we can always test estrogen. The thing is that perimenopause is a diagnosis made of clinical findings. So it's a clinical diagnosis, not a lab diagnosis. And because we're fluctuating estrogen so wildly, some months we may be fine, some months we may not be fine. So sometimes we might be bringing in estrogen spray, gel, cream, patch, just 7 days before your period, because that's when, I'm really starting to feel it. And if I give you progesterone, that's going to compete with estrogen. And so then you're like, yeah, and then the day before my period, I do feel really hot and sweaty. These are all things we want to be looking for. The other thing that can happen outside of brain changes is we can start to have weird symptoms no one ever talked to us about. So maybe we're having cold flashes, we're having burning tongue, we're having joint pain and muscle aches. Maybe we're getting like electrical shocks and we're like, where is that coming from? Or maybe you're getting headaches a few days before your period. These can all point towards estrogen declining.
So I'm thinking about this friend of mine that I've known her for 30 years, and now I know she's got ADHD. But at the time, I was like, what is wrong with her? Like, she can't get it together. And I felt really bad for her. And I was like, I wonder if she's even going to make it because it's every day is a struggle. And she's now in perimenopause. Well, I would say postmenopause now. She's just really struggling the last several years. I'm trying to help her through it. And she's very fearful of hormones, which in the beginning, and I've been so slowly educating her that it's not a bad thing. And she's now getting convinced. Okay, now I'm ready. And she wants to get hormone therapy and she's convinced this is going to really help her. And she's a kind of person, just can't get it together in terms of diet and lifestyle, which I've been preaching for years. And it's up and down, just like many people. You start, you stop. But I think for the ADHD brain, it must be even harder to get these habits in. So what's happened to her? Maybe you get some advice here as well. So she finds a doctor and the doctor creates more fear in her. And it's very wishy-washy. It's hard enough for anyone to find a good menopause doctor. And she's researching, looking for a menopause doctor. So these are supposedly qualified. And I don't know what's happening in the conversation, but maybe with the ADHD brain, she's interpreting things differently. But because she gets some information and is now in high alert, I don't know if she'd do this, maybe not. Okay, she gives it a try, doesn't quite work yet. Then she reads an article saying how bad hormones are for you. Because you can find studies on good hormones, bad hormones. And
if you go back to the Women's Health Initiative study, it's like, hormones are going to kill you. And I'm like, well, we don't use horse pee anymore. I can assure you of that.
So I'm feeling really bad for her. I'm like wondering, is the doctor just saying certain things and maybe she's interpreting it wrong, or she just get bad luck and her ADHD brain sets her down these rabbit holes of getting more information and getting the wrong information? How can I help her?
Yeah, well, hyperfocusing is real in ADHD. And when something becomes your special interest or you are needing to understand that it's like an itch in your brain, you are going to go down a rabbit hole and you're going to read everything and anything. And there's a lot of doctors who still operate under the myth that the Women's Health Initiative was the end all be all and that hormones are going to give us cancer and kill us. And they're just not as up to date with the current research. Somebody who's been prescribing hormones for 15 years, and believe me, I've been through the ringer with gynecologists who have sent me letters saying, you're going to kill this patient because you're giving her progesterone. And I'm like, I don't think so. I don't think that's what's going to happen. So let's talk about this because, firstly, if you try hormones and you're like, it didn't work in a couple weeks, that's not an uncommon experience. In fact, it can take 3 months for us to really get that dialed in and get things working. So when, with progesterone, we usually feel that one quite quickly. With estrogen, we want to know what's the lowest, most effective dose for you. That's where we're going to start. And so you may start that, and then we may test your blood 6 to 8 weeks later, and we see that, okay, we really want to get you like closer to 100. So in the lab testing, if you're postmenopausal, we don't want to see you at postmenopausal levels. We want to see you somewhere in the 60 to 100, maybe higher range. And so if we don't see that, we're going to increase your estrogen. We're also going to go off your symptoms as well. And so it may take 3 months before you're like, okay, I'm really starting to feel this estrogen. The same is true with testosterone. I will tell you, because we dispense testosterone as the male testosterone, in Europe, they just got testosterone for women. We still don't have that. We're using off-label men's testosterone. We're using a sachet. Usually we want to start people like around, you can have sensitive people, you start them at 0.5. You can't do that with a sachet. You're going to have to compound that. So if we're wanting to start you at like 2.5 or a lower dose, like that's hard to measure out. And because women have access to that, and they're like, I don't feel the testosterone, it's been 2 weeks, they start to increase it. It can take 3 months for you to feel the effect of the current dose of testosterone. And if you go past that, you may end up with cystic acne, hair loss, and hair growth on your chin. And then it's going to take 3 months for you to walk back out of that. So I always think it's important that we have realistic conversations with women about the expectations they should have about hormones, because there is always that person out there that's like, I put on the estrogen patch and the next day I was Superwoman. And I'm like, I love that for you. And that's not always going to be a common experience. Now, to the concerns about health risks, the biggest concern women usually have is around breast cancer. What's interesting is if you go back through the decades of data, we have found that if you were on estrogen only, you didn't have an increased risk of breast cancer, which also makes sense. I've heard a lot of experts say, if estrogen was driving breast cancer in all of these cases, then why aren't we seeing breast cancer when your estrogen is so high in your 20s? Like we're seeing it in women who no longer have estrogen. So what we've come to understand is the synthetic form of progesterone called progestin, which doesn't give you allopregnanolone that we were talking about. So sometimes that is a better choice for someone who has a history of PMDD, but that is what's being implicated now as the increased risk in breast cancer, because we're seeing when we use synthetic progesterone, that progestin, we have that higher risk. But if we go with body identical, we actually don't see a similar risk. And so I think that's really important to understand. The other thing is, as well, is that we're not going to just give you these hormones and then not monitor you. We're still going to say, do your regular mammograms. Let's make sure that we're actually palpating the breast. So doing a physical examination. If you have dense breasts, we're going to get you in for ultrasound. We're going to monitor you as well. We're going to encourage you to monitor yourself. But as research is coming out, we're starting to question if maybe estrogen is actually protective here, and that we've got that story wrong all along. We certainly need more data in women's medicine so we can say concretely who exactly is at risk and what exactly is the best formula for everyone. But what I think is important to understand is that so often when it comes to women's medicine, it is bikini medicine. Wherever a bikini would lie is what we care about. It's your breasts, it's your uterus, it's your ovaries. But you are also a beating heart. You are a brain, you are bones, you are a musculoskeletal system. And we know as these hormones decline, all of those systems get impacted. And we have to start weighing the risk and the benefit. Because if I tell you that the odds of you dying are much higher if you have a hip fracture, like significantly higher in the first year following that hip fracture, like we have to start weighing that. Look at your bone density now. Is it worth taking the risk of not being on estrogen and possibly facing a hip fracture? No, most of the time it's not going to be. And so we have to start looking at all of these aspects. We're also starting to understand as the heart associations are coming out with guidelines saying that yes, estrogen therapy may actually be protective against the number one thing that is killing women, which is not breast cancer, it is heart disease. And so we have to be looking at that as well. As women's estrogen declines, usually their cholesterol goes up, insulin sensitivity goes down, and visceral adiposity increases. In my book, I go through why visceral adiposity is so bad for the ADHD brain. But in context of this conversation, that is going to increase your risk of diabetes, of cardiovascular disease, and dementia. We don't want any of that. So we want to do everything we can to mitigate that. Is that helpful in terms of the conversation with your friend?
Yeah, no, absolutely. And it's this conversation I would have almost with anyone too. Like this is such useful for people who even don't have ADHD. But I'm wondering how hormones are affecting the person with the ADHD, because you treat people who have ADHD, other people who don't. Are you seeing, is it harder to treat somebody with hormones with ADHD?
Progesterone is one that can be a little trickier, just depending on the hormone sensitivity, the history of PMDD, and if there's neuroinflammation. And so what I'll say that makes it harder with estrogen is that once neuroinflammation has set in, it can be a lot harder to get the benefits of estrogen in the brain without doing additional work. So that's why we want to try to intervene sooner with these hormones. I would also say that even if you've lost your uterus, a lot of women with ADHD struggle with histamine intolerance, with MCAS, which is mast cell activation syndrome. And we know that if we give you estrogen, that's going to increase histamine. And if your ovaries are still able to make estrogen, that histamine will cause more estrogen to be in the system. And so that can make you feel like you have flu-like symptoms. You can rage. You might have anxiety, depression. So we always want to accompany that with progesterone. And if you're a woman who has endometriosis, ADHD women are twice as likely to have endometriosis. We also always need to have progesterone on board, even if you've had a hysterectomy, because we never want to stimulate the lesions that weren't excised, that are just waiting in the wings, just hiding and waiting for that unopposed estrogen to come out. Now, when it comes to testosterone, testosterone is so overlooked in women's brain health. If you wake up flat, you have no motivation, no energy. You have a hard time getting started in a task, but you can't even follow through and finish it. You just feel flat all the time. That can be a sign of testosterone being low. And especially when we start seeing difficulty putting on muscle or being able to maintain your muscle no matter how hard you work out. So with testosterone, what is tricky with the ADHD brain is that when you give testosterone initially, even sometimes a low dose, women can have significant impulsivity issues. I always joke with my patients of like, hide your credit card for the first 2 weeks of this, because that's typically when I see things are at their worst. Because when the brain is like, oh my gosh, when we have testosterone again, we see kind of that male archetype of extreme impulsivity, like risk-taking behavior. But as women, that impulsivity can sometimes look like binge eating. So going in and being like, why do I have to eat all this chocolate and I can't stay away from the chocolate? Not that I hate chocolate. Or like overspending. So online shopping can be really problematic. And this is where patients will be like, yeah, so boxes keep showing up to my house and I don't even remember that I ordered this much stuff. So that's the thing with testosterone we have to be cautious about. But after 2 weeks, things usually start to level out, and women feel, I will say they feel fantastic initially. If they were low in testosterone, they're like, I have more energy. I'm actually like doing what I'm supposed to at work. I'm following through on things. Like all of this is improving. It's just initially, sometimes I see that impulsivity issue that I'm like, let's just note that. So it's not that these hormones are necessarily more difficult to prescribe in these women. It's that you do have to work with someone who is neuroaffirming. That is, that they don't treat you like your ADHD is some disease that needs to be cured, and also understands the nuance. This is why I teach at medical conferences all over the world, and they bring me in for this nuanced prescribing of like, how do we prescribe for the neurodivergent woman? How do we prescribe for the endometriosis woman? Like these patients that we're told, like, it's just so difficult. They're so sensitive. They have all these problems. And it's like, well, they still deserve access to this medicine. So let me help you out. And I will say, I teach a lot of medical doctors on hormone prescribing, and it is just so amazing to see how many of them are not just interested in this, but they're very interested on how to do things in the best way for women. And that is so inspiring to see, because 15 years ago when we were having these conversations, medical doctors didn't want to hear anything about hormones. And now we're seeing it's not just a new generation thing. We're seeing across the board. I'm teaching at a conference here in just a couple months, and it's going to be several thousand medical doctors, DOs, nurse practitioners coming in to learn how to do really nuanced hormone prescribing and support their patients.
Oh, that's so good. So needed. It's definitely, we're lacking on so many things in this front. And I'm hoping our daughters will have a lot more, it'll be a lot more clear for them eventually, hopefully. But I'm thinking again about my friend, and I know that this could be for anybody who's living with ADHD. So it's been a struggle for, I guess, her whole life and trying to manage it. And you somehow get by. Then you go through perimenopause and you struggle even more, and you really feel like you're falling apart, and things do fall apart. Like it seems it's like the bucket is just full. Your relationships, your kids, your bank account, or whatever it is, like it's really struggle to get through it. And the weight gain, and that's also very frustrating as well. So you imagine this, your patients, you get them on the hormone therapy, and they hopefully start doing some of the diets and exercise practices that you're recommending. Once they settle down, let's say by the time they're 60, like figure this all out, do they get to a point that is, so if their baseline is here, then perimenopause is high up here, do they get even better, like by just getting things smooth out, or they just get regular to their baseline, their ADHD brain?
Are you talking about if we intervene with hormones, or what
if you
specifically?
With hormones, and then hopefully diet and lifestyle, because we always talk about hormones with doctors on this episode and this podcast, but many of them goes without saying that diet, exercise, lifestyle, sleep, and all these things are really important. But maybe I'm wrong. Maybe there's other things.
Well, let me just plug how important exercise is for the ADHD brain, because this is something I think we're like, oh, exercise is good for us, but there's something very specific about exercise for the ADHD brain that every perimenopausal woman can also leverage. So a couple things here. Number one is the ADHD brain, not so good at using glucose, but when you exercise and you get sore, that's lactic acid. That goes to the brain, gets converted to lactate, and now it's a backup energy supply. So I like to say if the mitochondria is the power supply to the house, then exercise is a generator, but it's a crank generator. So you got to go work it. And if you want to be able to get that lactate up. The other thing is that ADHD brains may have lower levels of BDNF. That is a very important molecule. We call it the miracle grow of the brain. It helps with neuroplasticity. So as you go through this neuroendocrine remodeling of perimenopause, you need BDNF. The ADHD brain's already lower on it, but exercise actually boosts that. Now here's maybe the best thing that would make you want to exercise, and is that research shows if you can do physical activity, usually like a zone 2 cardio for 20 minutes, you're going to get 2 to 3 hours of attention and focus that is peak, that is your best. So this is something that before I got on with you, I was like, I'm going to go ride my bike for 20 minutes because I want my brain to be firing at its best as I go into this conversation. So if you've got a presentation, if you've got a parent-teacher conference, I also use that for that, because I swear for every ADHDer, we have so much trauma around being in school that like going there, I'm like, I just want to check out. I want to be inattentive right now, but that can be really positive and really help. As our estrogen declines, we have a decline in blood perfusion to the brain. Exercise helps overcome that. So there's very specific mechanisms. We always talk about exercise for metabolic health and cardiovascular health, but when it comes to your brain health, it's one of the most important things that you can be doing every day. Now, when it comes to hormone therapy, it's not an ADHD treatment, and it's not going to make your ADHD go away. Nothing's going to make your ADHD go away. It's always going to be there, and you're always going to have some challenges to overcome. But the hormones make it easier. And I will also say, in addition, we talked about neuroinflammation. There's also increase in reactive oxygen species. I think the mitochondria are amazing, except for this, I would call them lame and unfair, is that when reactive oxygen species, which are ripping apart cells, get upregulated, the mitochondria see that, and they're like, cool, that's what we're doing. I will also make reactive oxygen species. And you're like, no, friend, that's not what we're doing. Like, please stop. What is so interesting is that research has looked at animal models, and they've looked at specifically Ritalin. If you have an ADHD brain, if you have inflammation on the brain, so this can also be why women in perimenopause say, wow, Ritalin really what made my brain work better. the Ritalin actually helps bring down the reactive oxygen species and the inflammation. But I want to caution everyone, because if you don't have a true ADHD brain or you don't have neuroinflammation, that Ritalin will increase reactive oxygen species and increase inflammation. So every Silicon Valley tech bro that thinks they can just pop some Ritalin to work all night is actually harming their brain if they don't truly have ADHD or they don't have neuroinflammation. And we can't measure neuroinflammation, so we never really know. They induced it in these animal models and they made the animals have neuroinflammation. So they knew, they gave them that, they performed better, their brain operated better. And so this is one thing that if somebody has given up on ADHD medication because it doesn't work so well in your luteal phase or it stops working in perimenopause, sometimes partnering that with the hormone therapy actually gives them better results. And it's not because, oh, you're just taking stimulants to cheat or whatever dogma people like to say out there. It is because on the biochemical level, it has neuroprotection. It's saving your brain from inflammation and reactive oxygen species. And it doesn't mean that's the only thing that will work. Things like saffron, turmeric, acetylcholine, bacopa, those are also really helpful for brain health and can help with neuroinflammation and reactive oxygen species as well, and can help with the mood and the focus issues of ADHD. So there's all alternatives out there, but I do like to mention that medication and ADHD stimulants because, one, I know they're highly stigmatized, but two, I also know that's what women are usually going to be offered from their doctor first.
Yeah. So I'm wondering then, exercise sounds like a really great medicine for anyone. In general, we know, but maybe particularly important for anyone who has ADHD. So I'm wondering, because you mentioned sometimes the people who have the ADHD brain, let's call it, can get hyper-focused. Like my friend wants to dig into every single research paper she can find. Do you see with your community in general, people who have the ADHD brain, do they get hyper-focused with exercise when they feel that stimulus or they feel better, or is it really hard like anyone else just to get started and they stop and start again?
This is why we look at, there's so many athletes who have ADHD. Simone Biles is like one of the most vocal ones, undeniably complete badass, right? And if that's something that they're interested in, they will get really hyper-focused and dialed in on what's the ideal routine, what are my macros that I'm eating, making sure that they're training right. And so you don't have to be an Olympic athlete to do that. But I will say that there's a whole chapter in my book about exercise, and I go through all of the reasons you don't want to exercise because of ADHD and how to overcome it, because it's not a lack of willpower. And a lot of ADHDers will feel good, and they know they feel good when they exercise and everything works better, but maybe they have sensory issues. Like the gym clothes give them the ick. Like they just can't handle the way that feels. And so that's like something obstructing them. Maybe it's the time blindness like I struggle with. So you get dressed, you put on your workout clothes, you're like, I'm going to finish this task. And before you know it, it's 5 p.m. And you're like, where did my day go? How did I not get to working out? So yes, we see a lot of ADHD athletes. We also see a lot of people who struggle to have a regular routine with exercise because there's just so many executive function pieces that are necessary to getting this done. Sometimes it's also just like the thought of, I have to get in the car, drive to the gym, get to the gym, go to the locker, open up the locker, remember the code to the locker. Like all of these steps becomes too cumbersome. They become too overwhelming for them because that all requires executive function to plan all of that out. And many of us, if we're doing that year after year, we get on autopilot. Like it's just what you do. But if you're new to it, that can be one of the areas that's obstructing you from being able to exercise. One of the tips I give in my book is that if exercise is a challenge for you, you can try body doubling. So body doubling is just having someone else present will get you to actually follow through on things. So maybe you call a friend or you're sending voice notes back and forth while you go for a walk. Maybe you get yourself an exercise bike that has an instructor there and you can see that person, and that works for your brain to say, okay, I'm going to stay with it. Sometimes what we got to do is we got to just say, all you have to do is 5 minutes. Just do 5 minutes and see what happens. And usually people will keep going for more than just 5 minutes. And the other thing is, make it a special time of something you look forward to. So if you have a favorite podcast like this one right here, you can say, this is when I listen to my favorite podcast. I can't wait to work out because I am going to listen to my favorite podcast. You can also bring in lots of stimulation. I think cardio is the most boring thing in the world. My husband bought me this Nordic track bike. It has a screen. I'm riding through the jungles of Costa Rica. So I've got all this visual imagery. I have my Kindle. I am also reading a book while I'm blasting my favorite music. That is so much stimulation coming in. station just to keep me seated there. And sometimes I'm also like sending voice notes to my assistant and working on other projects and doing other things. And so it's okay if that's what exercise looks like for you. There are so many people out there that will say, oh, people, like research shows, if you watch TV, you don't put as much cardio output. Well, watch something scary on TV, maybe something that's really stimulating for you. I read romantasy books. Like, you better believe, like, just the other day, we were like in this fight scene in my book, and I was trying to do zone 2, and I look and I'm in zone 5, riding my bike so hard. And I'm like, oh, well, I should probably do some sprints here or something, because like I'm amped up. I'm like, oh my God, I don't want to die. Everybody's in this fight scene right now. So there are just different hacks that you can use. And just because the neurotypical brain might say, that's cheating, you shouldn't have to do that, that means you don't work as hard, whatever they say, if it gets you to move, who cares?
Exactly. Well said. Okay, well, I'm going to have to wrap this up. And I've got one more question, if you're open to that. I would love to leave somebody with some practical tips. Mm-hmm. So what would say the 3 top tips for getting through menopause when you have ADHD?
Start your day with protein. Start your day with protein is going to be the first one. And the reason for that, I want you to fiber all the other stuff too. But the reason why I want you to start your day with protein is that's going to set your metabolic health for the rest of the day. And that signals to the body that we've got enough building blocks that we should synthesize protein. The most important part of our day to get protein is going to be morning. And if you're trying to hit like 100 grams, I want you doing that earlier in the day, not trying to get 75 grams right before you go to bed. The second thing is safeguard your sleep and do whatever it takes to get good quality sleep. So when we sleep at night, the lymphatic system, I kind of like to call it like the dishwasher of the brain, because you've been loading the dishwasher all day with your thoughts, with the metabolic waste that you've had to generate in order just to think and do what you do. And it's when you get into that deep sleep that you run the dishwasher and you clean everything and you rinse it all away. And we need that. It's really important for the brain, because as much as lactic acid is great for energy, if you don't clear it out at night, it's working against you, which is very unfair. So in perimenopause, maybe that looks like progesterone for you. Maybe it looks like L-theanine, very well studied in ADHD, also well studied for helping you get into that deep sleep that you need. Apigenin is another molecule. It's an extract of chamomile, phosphatidylserine, and then magnesium glycinate. I think all of those can be really useful tools. This is on top of you doing the sleep hygiene, but I'm not about to tell a perimenopausal woman, all you need to do is have a dark, cool room and you're going to get sleep. It doesn't always work that way for you, but safeguarding your sleep is absolutely necessary. And then the third thing I would say is build muscle. Like, you're the CEO of building muscle, okay? Like, you are the boss of this. And the reason is because the more muscle mass we have, the better our outcomes in life. But also, it acts as a glucose sink. It's going to help with insulin regulation. We didn't fully get into all of that, but when we have insulin dysregulation, that actually disrupts our ability to use dopamine in our brain. So your blood sugar and insulin, the hormone that regulates it, is directly impacting your executive function. Building muscle mass, the more muscle we have, the more mitochondria we have, the bigger, meatier muscles, that's correlated with bigger, meatier brains, so to speak. You're going to have a lot more mitochondria there, and we need those, because as we go through the perimenopause transition, we need all hands on deck to make the energy so our brain can do what it's meant to do. And I know that none of this sounds sexy. If you are needing a place to start, you can go to drbrighton.com/plan, and that has a 7-day meal plan, recipe guide, that's an anti-inflammatory guide that's going to help you get 30 grams of protein every day. It talks you through exercise, gives you an exercise plan of where to start. It talks you through sleep, and it talks you as well through stress. All of that is really important. And the guide, I designed it for perimenopause weight loss, but as it turns out, it's the most effective stuff for your brain and helping you transition as well.
Oh, I love it. Okay. Well, you're going through this transition, more or less. And I would love to know, what do you eat in the morning for breakfast for protein? What does your sleep routine look like in general? I know we're never perfect, and what do you do to build muscle?
Yes. So I usually start my day eating eggs. It's like one of my go-tos. So I actually just had scrambled eggs with a bunch of veggies, onions, garlic. Those are important for liver detoxification. And then I usually have fruit with it as well. So I'm getting carbohydrates. I also will sometimes do like overnight oats. They're a great source of resistant starch, but I make them with yogurt. I've got a yogurt that has 25 grams of protein. I add protein powder to it. So I'm trying to get 35 to 40 grams of protein to start my day. And then in terms of exercise, I strength train typically 4 times a week. And the reason why I do that, because sometimes people are like, that's so much, is I don't do full body. So I break it up. For me, I have ADHD. I have a history of PMDD. I have these conditions that respond more to exercise. And so I usually do 20 minutes on a bike every day or cardio kickboxing. And then 4 days a week, I'm going to also add on the strength training. And certainly if I can ever do more, I definitely do more, but that's my minimum baseline. And so I'm working upper body twice a week, lower body twice a week. And that's typically how I'm spreading things out. I am also on testosterone therapy, full disclosure. So I had a accident last year and ended up having to have knee surgery. And following that, I started losing muscle mass. And even despite the strength training I was doing, working with physical therapists, I was doing literally everything. I couldn't put muscle on, and my orthopedic surgeon wouldn't discharge me because he's like, you're getting weaker. And we kept trying everything. And I finally said, I need to test my hormones. Estrogen's fine. Progesterone's fine. Testosterone's one of the lowest testosterones I've ever seen. And of course, because I went through a surgery that's not insignificant, and going through that, that's a stressor. But I'm 45. So I really was faced with, okay, I can't afford to lose muscle at this age. And do I try to boost my testosterone naturally, which of course is always preferable, right? I, again, love everything where we don't need a prescription, but I was like, I don't have time. And that's the reality. So I started on testosterone therapy, same exact routine, same exact diet, gained a centimeter in diameter of my thighs within 3 months, which my teenage son was like, how do you know that's not fat? And I was like, well, because I can physically see my muscles now, but also like my clothes are not fitting tighter. I went through all of those metrics. He's like, shouldn't you weigh yourself? I'm like, no, that's not actually that helpful. Like for just to get on a scale, I know that. But the physical therapist was like monitoring, and she's like, you've put on a centimeter. What have you done differently? And I'm like, the only thing is testosterone. To which my orthopedic surgeon, shout out to him, he was like, I use testosterone all the time in men who have like muscle wasting because they go through the same thing in their 40s. And he's like, but I never thought to use it with women. And I was like, well, how about now? And he's like, oh, I'm changing everything now. This is definitely changing. I am going to start like testing testosterone and looking at prescribing for women. And I'm like, that's amazing, because that really was the missing piece. And I think sometimes women are hesitant to start these hormones. But when you look at it from the perspective, like I very much was like, oh, but my estrogen and progesterone are so fine. So like I should be able to get there. And I'm like, you just don't have time to spend the next couple of years trying to climb out of a hole or a deficit. Like you have to get your muscle mass on because it's just so much harder at your age.
Exactly. How interesting. I love when we do our own little experiments and see what works. I'm wondering, because you had the surgery, did none of your therapists ever talk about blood flow restriction?
Oh, we did that. I had a NEMS unit that I was doing neuromuscular stimulation. So every time I worked out, so instead of just doing squats and lunges, I'd have a machine hooked up to stimulate, to contract harder. Yeah, and we did blood flow restriction, and things were not improving. And then once I started testosterone, I was just shocked at how my muscle was coming on, how I was able to lift more weights, do more reps. Yeah. So it's just a real testament to the fact that like without the hormones, you can't actually build muscle. This is why whenever I see men on the internet shaming women and saying, your hormones have nothing to do with like your metabolism. You just have to be in a caloric deficit. And I'm like, that's cute. Okay. Because like her estrogen being down also means she can't build muscle. Her appetite is out of control. This is not as profound. Well, yes, caloric deficit results in weight loss. What you're telling women is be skinny at any cost. Because the reality is that if she doesn't have testosterone and estrogen, she can't put on muscle, then she loses that weight. And all you did was put her at risk for osteoporosis. And I think there's some really great men in the conversation, but there are some men who just very much believe that small at any cost is what women should be pursuing. And I'm here to say that you are better off if you've been, let's say this is usually women who are like, I've been a size 4 my whole life and now I'm a size 8. Do you know your risk of death if something happens to you and you go into a hospital is so much lower because of that? And so while you're like, oh, I just want to be a size 4 no matter what, especially like in the Ozempic era, I'm like, but do you? Because being a size 4 at 20 wasn't costing you as much as it starts costing you at 50.
So well said. Dr. Jolene Brighten, I'm so grateful for all the work that you do and teaching not only us, but other practitioners as well. And for the woman who has ADHD, we have solutions for you. You can get the ADHD and Women book. This is a guide to optimizing your hormones and thriving with ADHD. And you, as someone yourself going through this perimenopause transition with ADHD, there's no one better to talk about this. And I will have links to the book in the show notes, as well as the website, your Instagram, TikTok, and of course, my favorite, YouTube. Is there anything else that you'd like to leave our audience with or share? Is there anything else that's coming up? Because the book, let us know when it's coming out.
The book comes out October 6th, and I think what is important to know is that I also wrote it for practitioners. So my editor was like, there's labs in here. You did all these tables with all the dosages for hormones, so women know the type of hormones, what dosages they should be looking for. And they're like, don't you think that's a little heavy on the clinical side? And I'm like, but did you not read the back of the book where I said how to use this with your clinician? So if you take this book to your clinician, maybe you buy a copy for them, you encourage them to get a copy, it is set up so that they can deliver better healthcare for women who are struggling with ADHD or ADHD-like symptoms.
Oh, great. So needed. Thank you, Dr. Jolene Brighten, and thank you everyone who's reached the end of the podcast. And I hope this was helpful. Go grab the book coming out October 6th and let me know what you think. And thanks so much, Dr. Jolene, for your time, and hope to see you again.
Yes, thank you for having me.